the genetic counselors up in the Greenville office. For those of you that are not familiar with me, I do a little bit of everything. One of those everything things that I do is some prenatal genetics. So this talk is all about sex, chromosomes, and NIPT. For those of you not familiar with NIPT, it's non-invasive prenatal testing or non-invasive prenatal screening. So I'm just going to go over a little bit about the technology. I feel like our range of how much exposure people in this room have to this is very wide, so I want to make sure before I get to the cases, everybody has a really good understanding of how exactly this testing works. And then talk a little bit about gender in NIPT. I'm going to use the word gender in this case instead of sex because it gets kind of confusing otherwise, and then go over some specific cases we had. So just the basics. It's non-invasive prenatal screening is what we prefer to call it because it is screening and not diagnostic, but most OB offices will call it non-invasive prenatal testing or cell-free fetal DNA. It analyzes cell-free DNA that is in maternal plasma that was collected in strep tubes, those like tiger stripe tops, and it was originally designed for Rh genotyping, but it is now used for aneuploidy screening. So cell-free DNA is isolated by centrifuging out the cellular debris and cellular DNA. It contains maternal DNA, which is from the adipocytes, which are the fat cells and white blood cells, or fetal DNA, which I hate that term because it's actually placental DNA from trophoblasts. It can be detected as early as 9 weeks for the purpose of NIPT, and it's undetectable in the blood after 2 hours after delivery. So a lot of patients will ask, could this be positive because my last baby had something or because I had a miscarriage a few months ago? And the answer would be no. However, if you have a loss that is still in utero, an intrauterine fetal demise, that DNA can still be found in the blood up to 8 weeks after that loss has occurred. So you have to wait a long time after that loss in order to do the testing. So there's two basic methodologies in terms of once a lab gets the sample, how are they analyzing that sample in order to put out that report. The most common by far is what they call the counting method. In fact, there's only one lab in the country not using this method, and most use massively parallel sequencing. So it sequences millions of short segments of DNA, and it's looking for representation relative to the whole. So if the chromosome 21 should be 3% of our genome, we would expect it to be 3% of that sample. That's the basis they're going off of in order to determine is the correct amount here. The number of standard deviations from the mean is calculated, and then if it's over a certain number of standard deviations from the mean, and each lab will use a different one as their cutoff, that triggers out a positive report. This is all done through a computer system. There's no person sitting there looking at it or analyzing anything. It's all completely automated. So, first of all, I made this, so I would like you to appreciate how beautiful it looks. But I wanted to show you guys what counting looks like. It's kind of like a binning method. So the darker blue is mom, the lighter blue is baby, and you can see when they see anything above what they would expect, that's when they would consider it a trisomy, and of course left would be a monosomy. The other methodology used is a SNP method. It's only used by one company called Natera. Their product is called Panorama, and it compares the SNP sequencing of maternal DNA, which they call a buffy coat, with plasma, and they use sample data as well as the Human Genome Project for their NATIS algorithm, which is just a term they've come up with, and they create a hypothesis for a monosomy, disomy, and trisomy for each chromosome individually, so they're not looking at the chromosomes compared to each other, but each one on its own, and they try and figure out which one is the most likely result for that chromosome. So this is courtesy of Natera. This is how they explain their methodology. They're comparing the maternal DNA versus the plasma in order to see what is the fetal chromosome copy number based on the fetal cell-free DNA pattern. I like to just kind of compare what can they do and what can't they do because they're certainly not equal technologies. So with counting, you can use donor eggs or IVF because you're not worried about what mom looks like in order to interpret what baby looks like. You don't have to make that assumption. And they can also do multiple pregnancies. Technically, they're approved to do twins, but they will take samples with 4 or 5 babies in there. If you send them, they don't actually say no to anything. But it's blinded to triploidy because everything is increased the same amount. The ratio to the whole is still the same. So I've actually had a positive triploidy amnio where I called the lab back and just asked them to look because I was curious, and they said it looks completely perfectly normal to them. They couldn't see a single thing about it. And it cannot detect uniparental disomy either. The other big thing is chromosomes that are high or low in GC content, like chromosome number 13 or chromosome X, may be underrepresented in the sequencing data due to poor amplification. It's because it creates that hairpin loop, and so the polymerase can't bind to that, and it's missed in the sample. So you risk missing those. So what they've actually done is they create a kind of correction bias. They assume they're missing so much of 18 and 13, but the problem there is if you overcorrect, now you're calling out too many positives that are not really positives. So that's kind of where they get stuck, is that not all the chromosomes are created equal in their method. The SNP side is hard to analyze because for some of these it's just because they're SNPs. For other of these it could be because Natera does not know how to do that. There's only one lab using it, so I don't want to unfairly bash SNPs, but they can't use donor eggs because they need mom to compare. They can't use multiples, but it can detect triploidy, and it will, because it's looking at each chromosome individually. It'll say, oh, there's a trisomy of every chromosome, and it has consistent sensitivities as reported by Natera across all the chromosomes. They say it doesn't matter about the GC content for them because it's not what they're looking at, and so they're just as good at trisomy 13 as they are at trisomy 21. However, about 4% of their samples come back as non-reportable, which means you get no result whatsoever. They just say, we couldn't analyze this sample, and we don't know, and you're going to have to resubmit a sample to us. So again, I don't know if that's Natera having problems with their technology or if it's the SNP method itself. So, accuracy. Accuracy is kind of a big word. The labs want you to focus on their sensitivity and specificity numbers. And I just put this up here for anybody that doesn't know. Sensitivity is the proportion of positives that are correctly called a positive, and specificity is the proportion of negatives correctly called a negative. That's not representative of the positive predictive value, which is what we in the clinic care about. What is the odds that this positive we're seeing with this patient is a true positive? What are the chances this baby is really affected? And that's influenced by the age of the patient and the specific condition. There are several limitations of this technology. I'm going to go into some of these more later, but patients with a history of transplant, patients on heparin and Lovenox, so those are blood-thinning medications for anybody not familiar, and actually it interferes with creating the library. They can't pick up enough fetal DNA, and the fail rate for patients on heparin has been reported as high as 80%. So in those cases, if you have somebody coming in at 12 weeks, they select an NIPT, 2 weeks later you get a failed result. Now you're out of the window for first trimester screening as well. So sometimes we'll just recommend that a woman just go ahead and get first trimester screening so they're not stuck with a quad later on. Maternal weight, and the big thing there is because the more fat you have, the more adipocytes, the more you're represented in the blood, it makes it harder for them to find more fetal DNA. Multiple gestations, because twins are not always equally represented. If you've got two placentas, they may not be putting out the same amount into mom's bloodstream. And the biggest thing with that is babies who have trisomy 13 or 18 are smaller and are putting out less DNA, so they're more likely to be missed, and then you get this kind of false negative because they're missing the baby that's affected. The American College of Obstetrics and Gynecology and the Society for Maternal Fetal Medicine say you should not order this on twins. I will tell you in our office we do, and the reason is it's still more accurate than other screening methods for twins. We just make sure the moms understand your test, your reduced risk is not as low as someone who has a singleton pregnancy. And then vanishing twin or triplets. So that's when you see a twin pregnancy at maybe that 8-week ultrasound, you say, look, there's 2 babies, and at 12 weeks, there's only 1 baby there. You still have to wait that 8+ weeks because that baby that vanished in utero can still be represented for that long, and they've been able to pick that up. And the most likely reason that baby vanished is due to a chromosome abnormality. So you're going to get this false positive and think the baby you're seeing on ultrasound is affected when really it was that twin that vanished. So the labs actually ask that you wait up until 20 weeks to do anything with those. And then the other thing I'm going to go into more about fetal fraction and mosaicism and maternal conditions. So mosaicism, the biggest problem is, of course, confined placental mosaicism. That represents 1% to 2% of all pregnancies. And, of course, NIPT would pick that up because you're looking at those trophoblasts from the placenta, but you're going to get a kind of false positive reading because the baby is not affected. Then there's true fetal mosaicism, so the baby is affected in some way, and that could be missed on NIPT because, again, you're not looking at the baby, you're looking at the placenta. So you have to think, how much is the placenta affected and how many affected cells are going to be picked up in that reading. And then the big thing is chorionic villus sampling, CVS, for confirmation of results may confirm a false positive, and this has happened in Greenville where a patient had positive trisomy 18 on NIPT, positive CVS said trisomy 18, baby was perfectly healthy, but it was a terminated pregnancy. They terminated based on the CVS results. So we caution patients that we understand you want earlier testing done. CVS is a diagnostic option used from 11 to 13 weeks typically. However, you're running the risk that that test is also not going to be accurate, that we're confirming something that was incorrect in the first place. So it's rare, but something that we add to our counseling to make sure patients are aware of that. So fetal fraction is actually one of the biggest parts of NIPT, but it's rarely talked about by the laboratories, and I think for good reason, because they feel like people don't understand it and they don't want to deal with it. It's the representation of the fetal DNA in the plasma. So a lower fetal fraction increases the risk for a false negative result. And people think like, oh, baby has an extra chromosome, you see all this extra material, but the ratio of a trisomy is 1.02 at 4% fetal fraction, and 1.05 at 10% fetal fraction. So it's not this huge increase in DNA, extra DNA that they're seeing when they have a positive. Average fetal fraction is about 10% throughout pregnancy. It does go up over time for a little bit and then kind of stabilizes out. And a less than minimum fetal fraction is what you get for a non-reportable result. That was 4% for sequinome and areosa, but I've heard that sequinome has started reporting out around 3%, that they've dropped it some. We don't use sequinome. And it can be as low as 1.4% for Illumina and Council, and that is what they say they will not report out under. The risk for aneuploidy is increased based on a low fetal fraction non-reportable result. Recent studies have shown that if a woman has a fetal fraction below 3% after 10 weeks gestation, that she has an increased risk for conditions such as trisomy 13 and 18, working off of that principle that those babies are smaller and they're going to be represented less in mom's bloodstream. And it's particularly concerning if you're getting a fetal fraction under 1%. That doesn't mean anything's wrong for sure, but it's something where they've recommended additional counseling for those patients, even if they get a negative result on their NIPT. So just going back to the accuracy part, these are the sensitivities and specificities reported by the labs themselves. So of course that's self-reporting based on their own data. The reason I included this is just so you guys can kind of see, for trisomy 21, everything's going to be close to that greater than 99%. And if you look at trisomy 13, it's as low as 91% in Council's column, and monosomy X is a lot lower, about 90%. But you'll see in Atera, that SNP platform, they report a relatively more consistent sensitivity and specificity value for all of their chromosome findings. And then, of course, you'll see fetal sex at the bottom. Council doesn't claim to report anything out, but most labs will say over 99% accurate on fetal sex. So positive predictive value, just getting back to that, this is just kind of to demonstrate this is why you need to know, what the prevalence is, so what's the condition, and what are the odds a woman that age would have a baby with that condition, in order to figure out how likely is it that this positive is a true positive. So, as you can see here, the labs will write in big letters on their report, 99% sensitivity and specificity, and nowhere for all but one lab do they put the positive predictive value. So OBs get the report and they say, well, there's a 99% chance that this is right and your baby has this condition. Well, if you're 25 with a positive result for trisomy 13, your risk is 9%. When I tell a patient that, no, I'm really sorry you spent the whole weekend thinking your baby was going to die, but your risk is 9%, not 99%, they tend to be pretty unhappy with that. So it's definitely a big problem that these labs want to dazzle you with these 99% values and don't really want to talk about the positive predictive value, but that, of course, is what we care about as clinicians. So this is just a slide I wanted to put in so you guys have it as a reference resource if you want to pull this out. This is a calculator that you can use. So it is free. You can just go online. You put in, I have the link there, the condition and maternal age. It'll auto-populate that sensitivity and specificity based on data it has, but you can go through and change that based on the lab you know your patient used and get a positive predictive value for your patient and a negative predictive value. So something to be aware of, just because as pediatricians, you guys are probably going to see in your general genetics clinic patients coming in that said, well, I had this test result in pregnancy, and what does this mean? And it's not always being confirmed by the general pediatrician before they're being referred to you guys, so that's a way to find out what are the odds for this parent that this baby actually has this. And if anybody really wanted to do it by hand, I have the actual calculation right there. I don't know why you'd want to, but Lori asked me to make something for her the other day, and I had to go do it by hand, so there it is. So studies on NIPT accuracy don't often actually look at fetal gender discrepancies. So a lot of times they'll just say, it's really accurate, but they haven't looked at any kind of cases or given any kind of numbers for that. They just kind of say, well, that's not what we're concerned about because we're not diagnosing a child with anything. You're not diagnosing a child as a boy or girl. There's no kind of positive or negative there, so it's skipped over. One of the most recent kind of meta-analysis found there's about a 99% detection rate for trisomy 21 and 13 and a 98% detection rate for trisomy 18, but they said the sex chromosome aneuploidy cases are too small to study, so they felt like there wasn't enough positives of them to get an idea of how many of the cases they were actually detecting. A recent study found only about 60% of women understood that there was any kind of risk after NIPT. So that means about 40% of women think, if I get a negative NIPT result, my baby is golden, and there's no risk for that baby to have trisomy 21, 18, or 13. The sex is 100% accurate. They went through and answered on their survey, you know, I would trust this over anything else. This is 100% accurate. And of course, the study found women with college degrees and master's degrees were much more likely to understand that there was a residual risk there and that this doesn't detect all cases. But unfortunately, at least in our experience, the majority of our patients are not patients coming in with master's degrees and not degrees in science fields. Many providers, when surveyed, said, there's too much information on this, it's too much technology, I don't have time to keep up with it, and I don't know how to explain it. I had an OB tell me that the only patient he thinks could understand NIPT was a rocket scientist. And that was him telling me that. And I said, actually, I don't think I explained it well enough for some of my patients a little bit below that to get what I'm offering them. But they oftentimes feel so overwhelmed by that technology piece and the counting method and the residual risk and all of that, that they just kind of throw their hands up and say, do you want to know if your baby has Down syndrome? We'll tell you if it's a boy or a girl too, and are over it. So, speaking of sex chromosomes, some labs just evaluate X and Y completely individually as chromosomes, and then other ones look for absence or presence of Y, and that's what they'll report out. We detected Y, therefore your baby is a boy, or we didn't see any Y, therefore your baby's a girl, but they're not actually evaluating for Turner syndrome, Klinefelter syndrome, those sex aneuploidy cases. Just kind of some pros. Sex chromosomes, I think, are important to include on NIPT, and they've done a lot of research showing why these conditions would be helpful to know about prenatally, as long as the patient wants that information. So early diagnosis of Klinefelter syndrome has been shown to lead to better outcomes and improved fertility preservation. Wake Forest is actually doing a big study in getting prepubescent males with Klinefelter syndrome in and doing surgery on the testicles in order to preserve fertility throughout the lifespan. So there's a lot of work going into that, but a lot of times patients with Klinefelter syndrome aren't diagnosed until adulthood when they already find out they're infertile. So they feel like this is one of the ways we can get more males diagnosed earlier. And then early diagnosis of Turner syndrome can allow for monitoring of heart defects both during the pregnancy and after the pregnancy, and better treatment for growth and hormones during puberty, because some females with Turner syndrome, again, can kind of slip through until things have already progressed to a point where it's harder to treat. And the detection of gender early on when mom is a carrier of an X-linked condition. So some physicians will use this to say, you're at risk to have a child with Duchenne muscular dystrophy, and let's find out if we need to worry about that. Is your baby a boy or a girl? And we'll use that information to help determine if you're going to get that CVS procedure, because we can't see if it's a boy or girl on ultrasound this early on. So there are people out there offering it for that reason as well. However, a recent meta-analysis, which I heard was talked about on Monday, found 91% false positive rate for Turner syndrome, XO. So most cases they're reporting out of Turner syndrome are turning out not to be babies with Turner syndrome. And there's no positive predictive value or negative predictive value that you can really use for gender because, again, it's not a positive or a negative. It's two separate categories. And then actually in China, a lot of patients use NIPT for gender selection, so they can get early terminations if the baby is a girl. And that's, I don't think, as big an ethical concern in the United States, but we have had one patient ask about using it for that purpose at our office, and we just declined to offer the testing. And then sex chromosome analysis can uncover things that would have been never known to the patient or child, benign conditions or things that wouldn't have caused problems until well into adulthood, that patients don't understand they're opting into when they say, oh, I want to know if the baby's a boy or a girl as early as possible. And I'll talk about that a little with the cases. So, this is the scariest slide in this presentation, but a lot of patients request the gender test. When requesting NIPT, they say, my friend told me that she found out at 10 weeks the baby was a boy, and how do I do that? And that can be hard to then explain to them why the test was designed and that we're not looking at sex chromosomes for that, but that incidentally it will tell us if the baby's a boy or a girl, because they're like, yeah, I don't care, I want to know if the baby's a boy or a girl. But the biggest thing is there is a company out there, they're called Sneak Peek, that offers direct-to-consumer gender testing for Y on NIPT. So you go online and you order the kit, they send it to you, you prick your finger for blood, you mail it back to them, and in 2 weeks they send you an envelope that says you're having a boy or you're having a girl. They do not go into their technology a lot on their website. I tried to find more information on what they're using. They do have a money-back guarantee. That is all I could find. And what this is their fact. If your baby is not the gender they said, not a boy or a girl, right? You get your $200 back. So this is their advertising, and they also offer it at 9 weeks. I will say that only Natera does testing at 9 weeks. Everybody else likes to wait until 10 weeks because of the fetal fraction issue. So I'm a little bit surprised they're starting that early. And they say, oh, we can give you results back quickly. They don't address anything about, we saw this amount of Y, or we are worried we detected this. The report just says, you're having a boy or you're having a girl. So it's a very scientific test with a not-so-scientific result. And multiple studies have actually come out and said fetal gender should be diagnostic on NIPT. RHD typing is supposed to be considered diagnostic on NIPT, and they said, well, fetal gender is just as accurate. You should consider that 100%. And I actually found that a group of obstetricians in Great Britain were using that as an argument for the NHS healthcare system, which is their big, government-funded healthcare system, to pay for NIPT. They said, oh, this is 100% accurate for fetal sex, or close enough to 100% accurate that you should consider it a diagnostic result. So the next thing, with you guys armed with all of that information about NIPT, is to go over some GGC cases and just talk about how fetal sex determination and sex chromosome aneuploidies have affected us in the clinic. I would like to point out that this is one office, so I feel like if one office is getting these cases, a lot of other places are as well, but they're just not talked about as much, and I'm not really sure why. So I tried to set them up uniformly and go over some clinical information, the result that patient got on their NIPT, the actual finding in the pregnancy, and then I tried to find out as best I could. I called these labs and I said, why was this wrong? What happened? Walk me through why you got this wrong. They were not very thrilled for me to ask them that. And then some of the patients we've seen as pediatric patients, so I also have some updates on them. I know this is a case I talked about a while ago, but I don't think everybody was in the room for that because it was at a case review. This was a 29-year-old gravid at 5, so it was her 5th pregnancy. P4, so she's got 4 live births, Caucasian female. The ultrasound revealed a tethered penis-like appearance. Well, this patient had gone out at 16 weeks and gotten a gender scan. For those of you that don't know, gender scans are done at places that are not regulated. Those ultrasound techs don't have to have any training whatsoever. They're not controlled by the FDA, so they're not a great idea. But she had bought all the baby girl clothes she could find. She was excited. She had 4 boys at home, and she wanted a girl. And she was not hearing us when we said, we think this is probably an abnormal penis. She said, no, I think this is a girl. So our first step was we said, let's see what NIPT tells us, because she would not at the time consent to an amniocentesis, and they reported out normal female. Just said normal female, there was nothing else on the report, and I said, I really, really trust the physician I'm working with, and if she tells me that baby has a penis, that baby has a penis. So I called the lab, and I just said that. I said, listen, this is what I'm seeing on ultrasound. And they said, well, there's like more Y than we would expect for a girl, but we didn't put that on the report because it didn't meet our threshold. So me calling was the first time a human had sat there and looked at that data, because since it didn't cross over that standard deviation above the mean, it didn't go out onto the report, it looked like a normal result, and they just didn't tell me anything. So armed with that information and knowing there's some Y material happening here that could be signaling something, I can talk to the patient on all the possibilities that I could think of, and they consented to an amniocentesis, and the FISH showed a 52% of the cells were 47XXY, or Klinefelter syndrome, and 48% were 46XX. So with that, we had to tell the patient, we can't see the genitals that well, and your baby has about 50% cells that would say male and 50% would say female. We are not going to tell you what gender this baby is before it's born. Well, that's really hard for the parents. She's already gone through it 16 weeks and celebrated having a girl, and then she came to our office and we said, might want to return some of those clothes. We think this is a boy. And now we're saying, well, we really don't know. And she had a hard time because she had already had a gender announcement and announced to everybody that she was having a girl. And we talked about that she didn't really need to tell anybody that this was happening and this was private information for her, but it was very emotional, and I think I saw that patient at least 8 times for an hour at a time during her pregnancy. So why did NIPT get this wrong? I kind of already said this one, but they only report out chromosome findings over their set threshold. They're not going to call you and say, this looks funky to me, because they don't usually know it looks funky because the computer's not telling them it does. They didn't report out any Y or give us any indication, so if this had been in a normal OB office, that patient getting her anatomy scan done, they probably would have said, well, it's a girl, congratulations, and carry on. And that's kind of my concern with this. They never alerted anybody. I had to call them and ask them what was happening. So it was a normal male appearance at birth, so good thing we did pick this up, because if she had been expecting a little girl the whole time and a boy came out, I think she would have been even more freaked out. And multiple karyotypes have been done since then. So the testicular tissue showed mostly 46XX, which is interesting. They had a skin sample done when they were paired as hypospadias, which had a pretty equal split between Klinefelter and female. Cord blood showed a pretty equal split, and then the FISH on the cord blood actually picked up a few cells that were 46XY, which haven't been seen in any other samples. He does have low testosterone for his age, so he's being followed closely by the endocrinologist, but other than that, he's doing really well. His development is on track. Dr. Rogers has seen him multiple times as a patient. But the parents, every time they come in, no matter what we say to them about how well he's doing and how we're not concerned about his health or development right now, are very confused. They're very upset. They still feel hesitant to call him a boy because they keep getting these reports back where they're saying, well, 50% of his cells are female. And, why is his testosterone low? And what if he identifies as a female later on? And this has really thrown them from a loop. And all of that from this screening test where, they never anticipated getting this kind of result. And the question I have, is when would this have been picked up, if ever, postnatally? Maybe at puberty, because his testosterone is low. Maybe he would have entered puberty late and somebody would have flagged it then. But certainly I don't think for a long time. And instead now they're dealing with this 1.5-year-old where they still can't even really fully relax and enjoy having him because they're so terrified that something is going to happen and he's not going to feel comfortable in his own body.
He does have a male gender name.
Yeah, they did decide to name him a male. They weren't sure if they were going to identify his gender right away or wait until he started verbalizing a gender, but they felt comfortable enough to do that. But even mom just is racked with guilt because she's so terrified she's going to make the wrong choice for her child. So the next 2 cases are actually incredibly similar, so I've lumped them together. Case 2 was a 38-year-old gravida-free, para-2 Caucasian female, and she was just offered NIPT for advanced maternal age. And she actually was in the office scheduled to meet with me, and she said, I don't want to talk to that lady, but she wanted the testing done anyway. So then she had to talk to me, so joke's on her. And the NIPT result showed an increased risk for monosomy X. The positive predictive value for monosomy X is, of course, not related to maternal age because there's no increased risk with maternal age. So most labs just use a general 50% risk number there. The actual finding was the patient's 20-week scan revealed normal male appearance, and she freaked out. She had wanted an amnio to begin with because she said she would terminate a child with Turner syndrome. She did not want to carry the pregnancy if that was the case. So we did do the amnio, and we found that he actually has, most of his cells have an isodicentric Y with a very low level mosaicism for Turner syndrome. And postnatal studies have revealed about 69% of the cells have that isodicentric Y, 23% of the cells have normal male, and then 8% have that Turner syndrome. So I told this patient, I think he's probably just going to be a healthy normal male. I think this is an incidental finding, and we wouldn't have known about this for a long time. It's hard for me to say how it will affect his fertility as an adult, but I don't think in the long run this is going to mean much for him. So this patient gave birth at a hospital I will not name, and the physician, when the baby was born, started yelling at the mom saying, well, you have a boy with Turner syndrome, and he has Turner syndrome. And the mom had brought my note that I had written for her to take to the hospital that explained what an isodicentric Y was, and given it to her, and she said, I don't speak to people who are under my level. A genetic counselor is not a physician, and she clearly doesn't know what she's talking about. So she would not talk to me, and the patient was hysterical. And Dr. Rogers can tell you this patient has asked him to call and complain to the hospital about this physician multiple times since this happened. And we have visited with them and said he looks great and he has normal male genitalia. His endocrinology visit was normal. The person who saw him in the hospital insisted he get an echocardiogram for his Turner syndrome. That was also normal. And he is doing very well so far. That mom, however, is still freaking out. Still. She cannot accept that, again, this probably doesn't mean much for her son's health. And again, something that you wouldn't really expect to find on NIPT. NIPT was saying, oh, this baby has Turner syndrome, and then when we do the amniocentesis because mom wants to know because she wants to terminate if the baby has Turner syndrome, we find this crazy result. I think the important thing for me here is it's easy for us in the genetics world to say, well, logically, we get it. That probably won't affect that male very much. But to this mom who has a high school education and nothing else, and she is trying to learn the basics of genetics on top of this, the only thing she can hear is, my child has abnormal chromosomes. My child is different. And it's very hard for her to let go of that.
Still angry.
She is still very angry at the hospital and the way she was treated. And that just shows, too, that pediatrician could not at all interpret the karyotype from our laboratory, could not interpret anything, and saw that positive NIPT and saw that there were some 45XO cells, and she was going with it. So only a few months later, we had a 22-year-old gravida-free, para-2 Caucasian female come in. There was a short femur identified at the 20-week and 32-week scan, so she was offered NIPT due to that finding. A short femur, for those that don't know, can be a soft marker for Down syndrome on ultrasound, so that's why she was offered screening. And she got a high risk for Turner syndrome. She wanted an amniocentesis, and they found that 41% of the cells had that isodicentric Y, 31% had a typical male appearance, and then about 28%, those numbers don't add up, I don't think, but about 28% had 45XO. So he's an apparently healthy 3-year-old male. She did not ever return for a follow-up. She had multiple visits scheduled and didn't show up. But this case occurred only 8 months later. And my big thing there is we are a larger hospital up in Greenville, but we're not seeing that many patients. And so to have 2 identical cases come up within 8 months of each other tells me this is happening more often than people realize, and it's happening more often than people are talking about, and yet nobody is consenting patients when they offer NIPT to say, we may find something like this that's going to sound really concerning and scary, but may not mean anything, or we may not really understand what it means for your child. So I called the laboratory, and on both these cases, they didn't see any Y material whatsoever. They rely on a specific set of sequencing data to be available, so they said it could be that the placenta is very skewed, and the placenta has mostly XO cells in it, and since they're testing the placenta, that's what they saw. But they also say that Y is by far the hardest thing for them to analyze, because X and Y are very homologous, they share many homologous regions, so they often miscall Y material as X and vice versa, and there's certain informative bins that they use for that sequencing analysis that they think could be missing when you have an isodicentric Y. And when I told the laboratory counselor about this, she goes, oh yeah, we get those all the time. And I was like, does anybody talk about it? And she was like, no. So she didn't seem to think it was that big of a deal, but she said, yes, we get cases like this often because there's some part of Y missing and we just miss it all together then. So case number 4 was a 40-year-old gravida 4, para 1, SAB2. That means she's had 2 miscarriages previously. She had genetic counseling due to her advanced maternal age and was offered NIPT but declined at that time. She had an ultrasound at 19 weeks and 4 days gestation, which revealed ambiguous genitalia. And in the prenatal world, that just means on the ultrasound, we cannot tell if that baby is a boy or a girl. A 2-vessel cord, an echogenic intracardiac focus, which is just a benign finding of calcium in the heart. And her Down syndrome risk was 82% based on her ultrasound and her age. And a lot of that had to do with the 2-vessel cord and the EIF. So she elected maternity genome by Sequenome. Maternity genome is a little bit of a different product. Instead of analyzing just 21, 18, 13, X, and Y, they analyze all of the chromosomes, and they look for anything bigger than a 7 megabase deletion or duplication. So they are looking for quite a lot more there. And her NIPT result, when I got the report on my desk, it said normal male. And I thought, oh, good, that sounds great. And immediately when I checked my email, I had an email from the lab counselor that said, don't read the report. We put male on it, but we don't really know, and we're going to call it indeterminate. So make sure you read that second back page with all the fine print. And I'm thinking, why did you write it on the report then if you don't want me to tell the patient that? And why is it on the second page in the fine print that you couldn't determine a fetal sex whatsoever? So I thought that was a highly odd way to handle that case, and I'm not even sure if I would have gotten the courtesy email had it not been a genetic counselor that I had known and worked with before. And they said they detected almost no Y material whatsoever, but they called it out as male because they saw a little bit of Y material. So the patient consented to an amniocentesis, and the karyotype actually revealed 47XYY. So we were like, well, there's actually a lot of Y in this baby. So what happened? And the report was reviewed because we specified ambiguous genitalia on the requisition. So she said, had we not put that on there, they would have reported this as a normal female. But because we had specified we can't tell what the gender is, they went ahead and reported that little bit of Y they could see. But it fell outside of their normal call zone, and I'll show you guys what that means in a minute. So they had no explanation for me on why that happened. And this is kind of their distribution in the call zone they use. You can see on the bottom, chromosome X, you would expect very little Y to be picked up, if any, in a normal female. So you can see 45X, 46XX, 47XXX, they should all be along the bottom part. But this baby did not have enough Y to push it into a normal male call territory, so they didn't know what to do with it. When cases land in this middle zone, each lab is left to independently decide how they're going to call them. A lot of labs would call that a normal female because they just assume they're incidentally, accidentally calling some X chromosome Y material, and others will report it as indeterminate sex, and then this lab decided to do both. The child is being seen twice by Dr. Rogers. I think he requests these cases. He pretends like he doesn't like them, but he's seen all of them. And the baby had extremely low blood sugar at birth and required 15% dextrose via IV. It spontaneously resolved at 1 month of age. I could not tell you at all if that was related to his XYY. We don't seem to have an explanation there. He has mildly underdeveloped genitalia, but it's otherwise doing very well. So these next cases are not as intense on the patient spectrum, but still incorrect calls on what I thought were interesting cases. Prima gravida just means it's the patient's first pregnancy. So case number 5 is a 26-year-old prima gravida, and NIPT result was normal female. Now, I'm not sure if everybody's familiar, but NIPT is considered the standard testing that should be offered to all pregnant women, regardless of high risk or low risk now. So these are both women that were offered this at their OB office, low risk pregnancy, and just opted into the testing. But the ultrasound showed a normal male. So we called the lab and said, you know, what's going on? This is not even ambiguous. This baby looks like a healthy normal male on the ultrasound. And they said, well, did you read that second page with all the little information on it and the fine print? And we went back and looked, and the baby had less than 1% fetal fraction. So we asked, well, why did you send us the report? You cannot possibly see enough information about this baby with less than 1% fetal fraction to analyze this. And they said, well, we got the computer to give us the results, so we reported it out. So this is a lab that has now decided that as long as their technology gives them an answer, they're not going to have a non-reportable cutoff. I find that very dangerous because they're not actually advertising their fetal fraction on the front of their report. So the OB, when reviewing the result, rightly said, hey, this is a normal result, and congratulations, and carry on. And if, you know, she had not ended up having a different result on her ultrasound, we would have never known. But our concern there was, well, how accurate is that negative result for trisomy 21, trisomy 18, and trisomy 13, and should we offer this patient a quad screen or diagnostic testing? You know, how accurate is the rest of that result? And not even a week later, we had a 21-year-old prima gravida who had a normal male result on NIPT, but the ultrasound showed a normal female, and the first thing we checked was that fetal fraction on that second page in the fine print, and sure enough, it was below 1%. It also concerned us because we said, how many patients are out there getting these less than 1% fetal fraction results? And we're not even knowing. They at least put it on the fine print on the second page on the back, but a lot of labs don't report it, period. It's nowhere on that report. They don't want you to know about it, and they said, well, it's confusing for the OBs. They don't even know what that means. We don't want numbers on their report. So they don't want to put it on there. Both patients were super happy about this mistake. Both of them were thrilled with what the ultrasound showed, so they declined further investigations. They said, sweet, that sounds great. But like I said, neither were flagged, neither would have been picked up, and I think if we weren't working in a high-risk office where they were more informed with what to do when we had these kind of crazy scenarios, they would have slipped by. But both patients, we did end up offering them quad screens, diagnostic testing, wanted to see if they wanted to investigate any of those other possibilities, and they declined. So this last case is a patient that had a normal male NIPT result, but a normal female on ultrasound, and we looked at the fetal fraction. No, that's normal, okay. The MFM came into the room, and she's running through the scenarios with the patient. She said, you've never had a transplant, right? And the patient was like, oh, my liver. And so we said, oh, well, is the donor a male? Yeah, it was a 12-year-old little boy. How did you know? And we were like, well, we found out why your NIPT was wrong. And so the concern there is that, of course, you're picking up those cells from the transplanted organ, but again, we have to question how accurate was the 21, the 18, the 13, and so had this patient at 12 weeks of her general OB been asked, have you ever had a transplant? Yes, she should have been offered a first trimester screen instead of the NIPT testing. And she said nobody ever asked her that, and she was kind of shocked that we thought to ask her, and very interested in why that mattered at all, because, of course, to the patient, they're not going to think to roll into their OB's office and say, by the way, when I was 12, I had a liver transplant. That's just not something that they would need to know, so the OB needs to know to ask, but they don't. So discordance in NIPT, there's a recent study that came out that looked at 206 cases, and it was done really well. They only chose cases where they had information on the baby postnatally and the placenta postnatally and could really analyze what these results were. They found that 88% of their false positive cases, 33% had a biological or technical explanation, which means the rest of those cases, they could not figure out any reason why NIPT should have been incorrect, but it was. Of their 12% of cases they looked at were false negatives, and about 54% were explained by a biological or technical explanation. So examples they listed for that were that mom actually is mosaic for a condition, or that the baby was mosaic, or there was placental mosaicism, things of that nature. But what that means is for a majority of the cases where NIPT is getting it wrong, we can't even give them that reason for, well, here's why the technology failed, and if we sort out all those cases, it would be perfect. No, the technology is still getting a bunch of cases wrong where there's no good reason it should be. They didn't include sex chromosome results as in gender. They didn't look to see if it was a boy versus a girl. They just looked at sex chromosome aneuploidy. So fetal sex determination relies on the ability to analyze that Y chromosome. As you guys heard me say earlier, a lot of labs just do presence or absence of Y. That at-home kit just does presence or absence of Y. So most algorithms will detect some level of Y chromosome in female pregnancy just due to the inaccuracy with the technology. So almost every result is going to show some Y, even though you have a female baby with a, of course, female mom. So they're assuming they're getting some kind of call wrong where they're calling X chromosome material Y material. And the cutoff value for calling Y then becomes crucial in determining when are you going to say baby's a boy versus a girl. A study in 2014 found that about 0.5% of cases where they called it a female were incorrect, and about almost 1% of male calls were incorrect. So about 1% of cases total are calling the gender out incorrectly, and yet that study came out 2 years before the British Obstetrics and Gynecology said, well, it should be diagnostic. So that's very concerning to me because for 1% of patients then, you are getting this incorrect result, and sure, sometimes it's going to be easy peasy explanation, oh, you're transplant, or things like that, but a lot of times it sends the patient into a tizzy, and they're very upset, and they want to know why. We lead down there into this amniocentesis, and we find all these crazy results, like in our cases, where there's rare mosaicisms or isodicentric Ys, and the patient at the start of their pregnancy, when they were opting into I want to know baby's gender, did not understand any of that. Another study I just wanted to point out that was done 3 years prior found a very similar false call rate. So my biggest thing over all of this is a question of informed consent. Do patients really understand what they're opting into when they get this testing? Are OBGYNs mentioning these possibilities? I can tell you no. And some laboratories are actually reporting out findings they're not validated for. So we had a case come back that it called trisomy 7 on NIPT, and I just included the lab on this one because it's important to note this lab is not validated to look for trisomy 7, and they tell you they're not analyzing chromosome number 7, yet they told me this patient had a baby with trisomy 7. Fortunately, this was done later in pregnancy, and we could already see that this was a normal, healthy baby on ultrasound, so we were able to tell the patient it's highly unlikely your baby has trisomy 7, but she still wanted an amniocentesis because she was worried about the possibility of fetal mosaicism, and it caused a lot of stress for her. And again, of course her OB did not consent her to trisomy 7 testing because according to what counsel's saying, they're not looking for that. So how would they have even known to consent the patient in the first place? There's also other rare findings. So a lot of patients have been, not a lot, but a good proportion of patients have been diagnosed with cancer based on this. Now, some people will ask, is a trisomy 21 that's positive, should you worry about maternal cancer? The answer is no. A lot of times it'll look like chaos on the report is what the laboratories explain to me as, because you'll see trisomy 21 and monosomy X and trisomy 13 and monosomy 18, there's all these crazy things going on, so it helps the lab be able to say, we think this is more than the baby, and we think you need to look at that mom for cancer. But they didn't know to do that in the beginning, and certainly no OBs are saying, hey, by the way, we might accidentally find out you have cancer if you do this testing. And then the other thing is we've had 3 cases in the last 6 months alone, we actually get this relatively often, where it came back and said, we think baby's fine, but mom might have Turner syndrome. So then you have to talk to the mom about, do you want to know if you have this mosaic Turner syndrome? What does this mean for you? One patient went into this identity crisis about, what if my mom would have terminated me if she knew I had mosaic Turner syndrome, and was very freaked out. A lot of times they can't separate out that this result doesn't mean anything for their baby, and most likely the baby's fine, and probably doesn't mean anything for them if they've made it to 37 with 4 children. Probably not going to matter much, but it still really freaks them out. Again, OBs aren't saying we might diagnose you with a genetic condition, and moms have been diagnosed with chromosome deletions and duplications, mosaicism for other findings, based on NIPT detecting something and reporting it back out. And if you really want to read more on this, I included all of the papers that I looked at. There were a lot of them. So that is everything.